novel this week, which is a blended in-person and virtual grand rounds. It's my pleasure to introduce everybody to Michelle Kahn, who's a graduate of our residency program. Many of you must know her. For those of you who don't, she graduated from our residency program in 2019 and subsequently went on to the Oculoplastics Fellowship at Moorfields in England. And through that collaboration, she's managed to recruit Dr. Verity to present grand rounds to us this morning. And that's very special because for us to have a visiting professor from Moorfields is not very common. And so, Michelle, thank you for arranging that. Dr. Verity, thank you for coming. And they'll also be co-chairing the AI and the I meeting tomorrow. So many of you will be attending. If you're still interested, I hope there's space, but I'll put a little plug for that meeting as well. Michelle, thank you.
Thank you. Thank you, Amandeep. Good morning, everyone. It's so nice to be back. Thank you for being here. I'm so honored to introduce Dr. David Verity today. He is a particular mentor to me. I did my fellowship with him at Moorfields in 2019, as Amandeep mentioned. They refer to physicians as Mr. Verity, so don't be confused if you hear Mr. Verity instead of Dr. Verity. Mr. Verity is a full-time consultant at Moorfields Eye Hospital at Nexal Surgery and Orbit. He received an undergraduate degree at Oxford, a research degree in immunogenetics in London, and advanced subspecialty training at Moorfields. He's currently the president of the British Oculoplastics Society and previous editor-in-chief of the prestigious journal Orbit. His academic achievements are endless, but as much as his academic dedications, he has dedicated his life to humanitarian service. He's currently the Hospitaller of the Order of St. John, which is the oldest charitable eye hospital in the world, and is heavily involved in training and education with that hospital. So today he'll be speaking to us about orbital disease, and I very much look forward to learning a great deal in the next hour.
To be here. People say two things about me: I speak too fast and I have an accent. Only one of those two is true. But it is wonderful to be here. It's nice to do this in person and also to speak to our colleagues on the video link at the same time. And I'm going to be sharing and rattling through an awful lot of cases today, so I hope you've got your seatbelts on. And if I see any little lag at the back, I've got a laser on this thing. It's a pretty strong one. So decision-making in orbital disease, when to intervene. Yes, no, maybe, and maybe not today. All right. So here's a picture of your boss, Professor Slomovich, and he's sitting there in the clinic, and he's got a patient in front of him with some orbital oma of some sort. And he's thinking, what should I do? Should I operate? Should I biopsy? Maybe I should do. Yes, I definitely will. No, I'm not going to touch this case. Possibly dangerous. Maybe. And then quite a lot of the time, maybe yes, maybe no. That's called a yes and a B. All right. But you're not quite sure. You start off by saying yes, and then you wish you regret it, and you say no just before you operate, or vice versa. So I'm going to go through a whole load of cases, and they're going to be yes, no, maybe, or maybe not today or tomorrow. Yes camp, diseases where we should intervene in orbital diseases like a Swiss watch at the orbit. If you get involved and things go wrong, you've got a big problem, okay? It's very tight at the back. Diseases which could threaten sight or life, which is many in our condition, or where surgery for aesthetics concerns is reasonable. So those are interventions which we say yes to. Diseases that we say no to are diseases which do not currently or unlikely in the lifespan of a human being going to threaten sight or life, or where the surgery carries unacceptable risks to the sight or life. And don't forget, it's surgeon dependent, not just operation out of a textbook dependent. And that's why orbital surgery is different to cataract surgery, because no one does 10 orbital cases in a row on a Monday morning. All right, so that's yes. And every time we go through this, we're going to have a blue yes at the top, we're going to have a red no like that, okay? And I might even test you as you go along, so test you at the end. And then you've got the maybe camp. And a lot of the cases that we see, I'm going to show you cases just from the last day or two, literally in London, where I'm really not quite sure where we're going with. So you've got the no, the yes, no, maybe no, and then you've got the yes. Now, of course, if you've got little experience, you should tend to say no, and the best surgeon is often the one that knows when to say no. When you're young, you think you can do it all, and then as you get older, you realize that as a percentage of what there is to know, you just know less and less and less. Okay, you don't believe me now, I'll just ask you in 10 years and you'll say, yes, you were right, Mr. Verity. I know less now as a percentage of everything. And of course, with your greater surgical ability, you're more likely to say yes if you think it's appropriate for that particular condition. But the problem, of course, is that with wisdom, you know when to operate and when not to operate. And so with wisdom, quite often, it's a no or not now to see which way the disease turns out, what the tumor biology is. Maybe there are immunotherapy regimes coming online which are more appropriate than operating on this patient, and I'll show you various examples. So we're going to go through some of the yes, and we're going to go through some of the no, and then we've got some bonus cases at the end, which are quite tricky. I'm not going to go through all of these, but I'm going to have a look at some of them. So orbital cellulitis. If I said to you a patient's got ptosis, do not go away thinking you have a diagnosis. There's a great mistake in medicine of describing something, putting it into Latin or Greek, and putting itis on the end and saying that's the diagnosis. It's a tissue response. Itis, cell tissues, is a tissue response. So orbital cellulitis could be anything. In fact, just before we set off, I was on the phone to Moorfields, and they've got a lady, they've just done a canthotomy a couple of hours ago, who's got a massive orbital cellulitis. I might show you the scans afterwards. Is it acute sarcoid? Is it something more serious? She said, the patient's got an itis. I said, yes, but what's the diagnosis? So itis is dangerous. I don't like the word itis, but you have to assume it's probably going to be infective, because if you treat infections first and you're wrong, don't worry. You've done the right thing. But if you don't treat an infection and you're wrong, worry, because you've done the wrong thing. Okay, you all know that, you're all nodding enthusiastically, that's good. Don't forget there's lots of other things that can cause an itis, and if anybody wants any of these slides as a PDF later, I'm not territorial, you're very welcome to have them, so don't take any notes, I'll give those to you later. And then don't forget that tumors can present with inflammation. Okay, tumors can cause inflammation. So when I see a patient who has an inflammatory orbititis, I'm really at sea, because I have to take the history, take tissue, and look at the scans. But if you assume it's infected first, you're less likely to have a patient who loses sight as a result. So this is the problem that we face. Now, one of these is orbital infection. And one of these is a high-grade lymphocytic malignancy that, to be quite honest, I can't remember which way around it was. Because actually, it could be either, couldn't it? And that's why we treat them aggressively first as an infective case, potentially, particularly if they're immunocompromised, but we leave the door open for possible other diagnoses. And that's so important. And imaging, of course, is important. But the first thing you do with a patient like this is you don't send them to the CT scanner, which will take 3 or 4 hours to do. Meantime, they've got a gas-forming organism in the orbit and they're going blind. You treat them straight away. Then you get the imaging. Okay, that's rule number 1. It's such an easy area to fall into. If you can get a scan in a few minutes, it turns out there's some other patient who needs an urgent scan. There's an abdominal aneurysm and there's a couple of others. And all of a sudden, your patient's shunted to the back. Treat them straight away, because that is the outcome, visual loss. So it's immediate antibiotics. Yes, yes, yes. See a patient, if infection crosses your mind, treat them as infective. And if that's the only thing we remember today, then that's the thing that's worth remembering. That's a really important message. And I can promise you, no matter how senior you are, it's very easy to slip into the risk of organizing tests and scans. Think, hang on, could this be infective? Because it could be. All right, so here's a case, orbital abscess. Now, these are absolutely classic. Patients go to a hospital, they've got an orbital abscess, and they say, we don't have an orbital surgeon, we'll send you to another hospital. And so the patients do the rounds, like this child had, for about 2 days, and he went to a hospital with an ENT surgeon, said, I don't like the sinuses, but I'm not an orbital surgeon, so I can't drain an abscess. Anybody can drain an abscess, right? Absolutely anybody can drain an abscess, because all you've got to do is to find out where the greatest degree of swelling is, make an incision at that point to release, as we call, release the devil, release the current material. So this patient had had an abscess, probably from an infected dermoid, curiously, very unusual. And there you can see the walled off abscess, you can see it right here. And that's very, very clear. And that patient had the abscess released, and you can see all this pus coming out. And when we release pus from an abscess, and we do this as soon as we can, if the patient's not improving on antibiotics, that's a whole new question, but if a patient has an abscess, when do you go in and drain it? Well, you can give them a short time on oral on IV antibiotics, because in children, they will often recover, but adults won't, because adults have a mix of anaerobes and aerobes. So in this child who'd been doing, unfortunately, had not been treated for 2 or 3 days, we went in and we drained it, and don't forget, scissors in, a big spread. And there'll always be a first time you do this, okay? You won't have the experience before you do it the first time.
If it's okay if we ask questions.
Please do, yes.
So you've said that you go IV, intravenous.
Yes.
Do you have any preference for what antibiotics?
For adults, we tend to go for a cefuroxime and metronidazole, but you might want to go for augmentin and metronidazole in adults, because adults have much longer drainage tracts to their sinuses. This all comes from sinus normally, not in this case, but it normally comes from sinuses. In children, their sinus drainage is much easier, it's a smaller cavity and a smaller, it's a more immediate connection to the nasal sinuses, to the nose. So they have aerobic infections, but adults have aerobic and anaerobic. So metronidazole, and it could be augmentin, so that's ampicillin, glutaminylic acid, or it could be cefuroxime or cefataxime. But we always talk to our microbiologists, and every year we update our policies and we talk to the microbiologists, what is the optimum given the pathogens out there at this current time. So children as anaerobes, adults as anaerobes and aerobes. Okay, so children as aerobes and adults anaerobes and aerobes. Now here's a gentleman, he's 21 going on 45 years old. Again, he had been unwell for quite some time. I don't have a pre-op picture, but that actually top right there is initially having been drained. So he looked very similar. He was 20 years in his 20s, but he was absolutely very unwell, sick as a dog, pyrexil, dehydrated, feeling unwell, vision started to drop to 624. And although by no means do all abscesses need to be drained, when a patient clearly is losing pressure from the vision from the pressure, and you can see here, all these sinuses are involved, and there's the abscess around here, and here's the abscess supernaturally. Those patients clearly need to be drained. And the astute amongst you will say, hang on, Mr. Verity, you've got infection in the sinuses medially, but this patient's got a lateral orbital abscess. And curiously, that's often the way, probably because the periosteum in the supralateral orbit strips off more quickly and more readily than the periosteum elsewhere. And this is probably local embolic spread of pathogens. All right, so now, the most worrying thing with these patients quite often, look at the loss of the inner diploe of the bone there, of the calvarium. These abscesses release osteolytic enzymes which can melt bone literally in days. So we had the neurologists see them and they were getting a little bit concerned because of the potential for edema and a spread of abscess. And that's why it's so important to drain these abscesses. They can be life-threatening. You don't need an orbital surgeon to drain an abscess in the eyelid. So it will happen to you one day. Okay, and you won't know when it's coming. It'll happen, but be prepared. And there he is. Afterwards, you can see we drained it and placed a corrugated drain in here, and you can see, and he recovered very well, and his vision was fine as well. All right, and always post-op, patient smiling. Oculoplastic surgeons always do that. Always post-op smiling. All right. So here's another one. This is a maybe. This patient, a very tight orbit, poor movements, fading vision, RAPD. And in children, either if you can't examine them or they're clearly getting worse on antibiosis, then really the die is cast and they should be drained. You cannot have a child that you cannot examine with a known infection. You have to make the worst case assumption that they have an abscess with orbital pressure, with all the risks entailed. So here's the list of when we would tend to go in. And you can see it's an incision. There's the abscess again, supernaturally, and it's an incision over the maximum swelling point. And you may be the world's best cataract surgeon, but one day you may need to drain an orbital abscess. Just remember this. Go for where it's most tense, at the general anesthetic generally, because you won't get deep enough. That's an incision, 2 malleables in, scissors, blunt-ended spread, and let the devil out, and wash it out with saline. All right, and you've done the job. Okay, that makes you an orbital surgeon. No, it doesn't. But the point is that you save that patient's sight compared to sending them to an orbital surgeon, maybe 6 or 8 to 10 hours away. So we're going to go on to some of the other, yes, benign cases. Necrotizing fasciitis. This is another one where we act without delay, because we know that necrotizing fasciitis, whilst it can be caused by any manner of organisms, is typically a beta-hemolytic streptococcus. Here's a case here. In fact, this is more accelerated, it happened. But when you're called to see a patient like this in ITU, I'm afraid the horse is often bolted. When you're called to say, Mr. Verity, or whoever, we've got this patient, they've been really unwell, they're in ITU at the moment with this necrotizing fasciitis around the eyelids. Could you come and have a look? By all means. But unfortunately, that patient's at high risk of DIC already. And this patient needs all the tissue removed as fast as possible. So again, you won't have any forewarning of these patients. You might see somebody this afternoon in your unit. And if you think it could be necrotizing fasciitis, go into 5th gear. Okay, you can't sit on these patients. Here's a gentleman I remember very well. I've been a consultant for a week and thought I knew it all. Call came up from casualty. We've got this gentleman. He's had some involvement of the lids with necrotizing fasciitis. In fact, he'd been in Spain abroad. And he was like that, he'd been on antibiotics for a while and he had to get back to the UK. So British Airways said, right, well, you can only come back if you wear a large pair of sunglasses, okay? Believe it or not, okay? Could have been some other airline, gotta be careful, okay? But he came back and this is how he was in the clinic. And you can see this massive amount of tissue rot on all 4 eyelids. It had partially healed because if you treat them long enough, they reach a mummified state. But it just goes to show you how much tissue necrosis you can have. If all of this was pulled out and he was reconstructed, look at the state of those corneas. He was hand movements on both sides with a secondary fungal infection. And so this is what we see, and you don't get any forewarning at all. But the message is necrotizing fasciitis, it spreads along tissue planes, remove those tissue planes. That's what it comes in. If you go deep enough to bleeding tissue. Okay. So some other slightly less problematic cases, dermoids and orbital surgery. Should you remove a dermoid? Should you? Well, we do tend to, particularly when the child is about 3 or 4. Why? Because if you look at this picture, about 2/3 of all the dermoids are anterior, and about 2/3 of those are up in the zygomatic suture, just the sort of area you might get biffed if you're playing football or even in the playground. So they can get inflamed if they're ruptured. And that's why we tend to remove them here. But 1/3, so 2/3 you'll be able to see or feel, but 1/3 are much deeper in the orbit, as you can see here. And they may present much, much later in life. Very proud of this picture. I remember taking it as a fellow, and it goes to show that you've got a supernatant of oil and proteinaceous material, and as you rotate it, you can see the dermoid, which is effectively like skin, dermoid, is constantly producing oil, protein, and keratin, and hairs even, as you can see down on the left here, and it's putting this into this structure. Well, it's no surprise that this is going to become inflamed. Anybody who's worked in the motor industry knows that if you use a high-pressure oil gun, and that's ever shot under the skin, you get a Calasian effect, ultimately, under the skin. So this is like an oil gun. That's why we remove them before they cause trouble. And so the question often comes, when to scan a patient with a dermoid? This is a question that comes up often. Is it a yes always? Is it a no always? Is it a yes maybe sometimes? So here's a rough guide. I don't normally put a child through a CT scanner unless they've got a medial anterior lesion, because your differential includes a frontal ethmoid or encephalocele. Rare they may be, but I'm always a bit uneasy about so-called dermoids in this area here. I'm more concerned about dermoids whose posterior I cannot feel, or I think they may be going through the lateral bone, like a dumbbell shape, a dumbbell like that, and you've got a posterior part, or it's atypical. But most of them aren't those at all. But if you had to have an aide memoir, be concerned about medial lesions. Yes, 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 do investigate them. But no, you do not need to investigate those dermoids where they're well-defined, where you anticipate them to be seen like this, and where you can feel it, where you can move them over the bone. And an experienced orbital surgeon, if she or he finds that it does go into the orbit, will be comfortable to remove the rest of the dermoid by following it through the bone. I'm not going to go into that now. Right. But here you can see the dermoid being removed. And this is right up here against the brow. Okay, I've just put a skin crease here. It's amazing through an upper lid skin crease how far the surgeon can then reach and can gently draw the tissues back. So a dermoid, for example, in the tail of the brow here, incredibly can be achieved and reached through a skin crease incision. We do not generally make incisions near the brow line unless we really have no choice. And the risk immediately, of course, is that the skin may tear if we were to try to access that through a skin crease. But it's important that we remove it in its entirety. Now, I like this slide because it shows us that dermoids often have a tail and they can reach into the bone, all right? And they often have a tail and it carries on going. And you can see this pit in the bone here, and that represents the old or the vestigial portion of the early epidermis. Okay, and if we don't scrape that hole out, that divot, what will happen? What do you think will happen? If we leave some epithelial cells behind, what do you think might happen? It'll come back. And that is similar to inclusion cysts. If you have a squint operation and there's epithelium buried under the epithelium or in the orbit, or any operation that breaches epithelium, up to 30 years later, patients can develop inclusion cysts. Same idea. I'm going to say a few words about thyroid eye disease. A very difficult area in which there are many yeses to when to intervene, many no's when not to intervene, and some very grey areas, because this talk is all about what is orbital surgery is not binary, what's clear on either end of the spectrum, and how do we deal with what's in the middle. If you look at thyroid eye disease, in general, that it is in general, you've got a hot phase, that's the red line, when it's active for a while, and then in general it calms down. And most treatments are trying to shorten that curve and abrogate it by compressing it at the same time. And that's what immunosuppression is all about, ultimately. And the blue line is how the patient looks. So in a perfect world, they will have teprotumumab on day 1, and they have no physical signs left at all, so the blue line just drops to 0 again. But in reality, patients are left with physical signs. And so yes, always topical lubricants, yes to smoking cessation and thyroid control, absolutely essential, because if a patient's not responding, they're probably still smoking, and yes to appropriate immunosuppression early on. But here are some not quite absolutes, but this I found is a useful aide-memoire guide. If you've got a patient with neuropathy, what do? Yes, you immunosuppress them, but we do an early medial wall decompression. So that's a useful aide-memoire. Patient comes in, optic neuropathy, we treat them in immunosuppression for a short period, but have a low threshold for decompression early on. If they're very congested with chemosis, consider decompression. So that's a yes as well. Urgent tarsorrhaphy, if they're so exposed they have a corneal infection, there is no choice, you have to complete an urgent tarsorrhaphy. So that's a yes. And then it gets a little bit more grey with aesthetic decompressions, and believe it or not, there are patients coming forwards now around the world who don't even have thyroid eye disease that are asking for decompression for purely aesthetic reasons. I'm not going to go into that. Personally, I think the risks probably outweigh the benefits. But this is the way the world tends to go. So we don't always decompress for aesthetic reasons, but we often do, of course. Okay, squint surgery is an absolute must. It's harder to live with 2 eyes and squints and double vision than it is with 1 eye and no double vision. Remember that. Quality of life drops with double vision. And lid rehabilitation is a very grey area of thyroid eye disease. We can always help patients, but we will never cure them and bring that blue line down to the bottom. The patients are never entirely happy. So when I see a patient with thyroid eye disease, at the very beginning, I say, I can help you. I say, but I will never make you happy. And I say that right up front. It's a terrible disease, and it affects young people, and often young ladies, and it's a damning disease. So there's a lot we can do, but you will never ultimately make them entirely happy because of the passage of time at the same time. So here's a patient, severe thyroid eye disease. This gentleman, very bad. And this patient here, there's a lovely technique for protecting the cornea. I was taught this by a senior colleague not that long ago. You put 3 sutures into the lower lid on a silicone bolster, and they are with tape stuck to the forehead. And you put 2 equal sutures in the upper lid, and they are then taped to the cheek. And you can reverse these and open the lids anytime you like to examine the cornea, and you can put them back and stick them again. And you have complete control of that cornea. Forget these jelly pads that are put on an ITU. They're just basically a medium for infection. But if you have something like this, you can control any acute situation. It's a lovely technique. That's a Prolene suture, if you have 4-0 Prolene suture. So with optic neuropathy, again, as I say, we have early steroids. So a patient comes in, optic neuropathy, colors have started to reduce, thyroid eye disease, thyroid control is good, they're not a smoker. What do? You give them intravenous methylprednisolone initially, 500 milligrams, and you can follow various regimes. Might be once a week for 3 weeks and then dropping down. It might be once every 3 days or so. And if it's really serious, you can go for 1 gram. And the complications have always happened where there's been 1 gram day after day. But if it's less than 1 gram day after day, the complications of hepatitis don't appear in the literature. So they either get better, and that's great, wonderful. And then we can give them radiotherapy as a steroid-sparing measure. So that's an absolute yes, that's very clear. But if they don't get better, we go for an early medial wall decompression. So that's an absolute clear yes. And the back of the strut, and I might talk about that later. But of course, with these immunotherapies that suppress B-cell populations, we've got much more powerful medication online now. And there's rituximab, and then of course there's the IGg4 receptor antagonist, teprotumumab as well. So your generation, if I show you this talk about surgery in 20 years' time, you'll say, what an ancient dinosaur that man was. He was actually doing surgery for thyroid eye disease because times are moving on at an amazing rate. And this is, they're congested. So there's lots of yeses in there about what to do. And a lot of medicine you don't know, but if you've got an algorithm in your mind, you know that you're probably not far off the best treatment. It's all about developing algorithms that you can then improve as time goes on. Be very careful of this sort of patient. It doesn't look like she's got bilateral optic neuropathy, does it? In fact, this lady had bilateral cataract surgery, because if you have optic neuropathy on both sides, do you have a relative optic neuropathy, RAPD? Do you? You don't, do you? So if both eyes, if both nerves have an optic neuropathy, you will not detect a relative afferent pupillary defect. Never be caught out by that, because it's waiting to catch you out. This patient had bilateral. So what do we do? Here's just a very brief discussion. You can see this is the there's the nose on the far left of your screen, okay? And the eye is under the malleable retractor here, and we just expose the medial wall. We go round the back of the sac. There's the sac on the cartoon. We can go all the way down the medial wall. We don't need to do this endoscopically. The ENT surgeons also do a very good job of it endoscopically. And this is the sort of results that we'll get. Here we have preoperatively, and you can see the medial wall here and here, and postoperatively. These lines will show you the difference. And you can see that we've created space posteriorly. We've created space posteriorly, and you can do the floor as well. But all it does is take the pressure off the box. That's all it is, like a tin that's too expanded. We're just taking the pressure off. IVMP does the same thing. It's just a question of how. Now, when it comes to vasculitis, remember what I said at the beginning. Inflammation is truly only a description. And there's lots of conditions that are called vasculitis. So what do you do with inflammation? You give them lots of steroids. And what a mistake that can be. Historically, we've had patients who've had pseudotumor. Put your hand up if you've heard that. Oh dear, it's still not out of the list. Pseudotumor is a really bad idea. I'll show you why it's a bad idea. Because people have trial of steroid. So, okay, we'll just try some steroid and people get a bit better. Do you know what? There's almost no condition that won't improve with some steroid. Meantime, if they've got something sinister, it goes undetected for a long time. So you give people steroids for pseudotumor. And well, you think, well, it's a pseudotumor, it's not really a tumor, and they get a bit better, so you make the assumption it's benign, but all the time your suspicion is delayed, investigation is delayed, and in effect, you're masking much more serious pathology. So this is the conversation I was having with my colleagues only this morning. Somebody pitches up with a lot of inflammation. By all means, give them a small amount if you have to, just to control it for that day. But be very aware of prolonged steroid without knowing the diagnosis. It's lethal, I can tell you. We've had patients who've had T-cell tumors and all sorts of other tumors whose treatment has been delayed by years because they've been on steroids. And are steroids without complications? Are they? They're not, are they? There's a lot of complications with steroids, which we overlook in our patients and our peril. Now, there are some inflammations that you can treat with steroids before you know what the diagnosis is, because this is all about getting a diagnosis. This particular patient had inflammation in the superior rectus area, so we biopsied him. But there are some, and this is probably the slide that I'm asked for most often when I give this talk. Say, well, actually, Mr. Verity, you're telling us not to give anybody steroids, but so who can we give steroids to when we're faced with a patient with inflammation? And broadly speaking, those patients in whom there's probably inflammation, but so posterior, there's a risk from the biopsy itself, as there would be here, risk to vision. It's reasonable to give them a short, sharp course of steroids, starting at a decent dose. Don't make the mistake of starting them at too low a dose. One of the biggest problems with steroids, because I spent most of my life in retinal vasculitis before I became an oculoplastic surgeon, people start the steroids at 20 milligrams, 40 milligrams. Utter waste of time, because you're going to get on top of inflammation, hit it really hard, like a cyclone, and then come off very quickly. That's the message of steroids. So you can do, she was sarcoid, as it turned out later, so we gave her steroids. Classic orbital myositis, scleritis. Doc, I woke up this morning, wasn't feeling too good yesterday, double vision, saw when I look in this direction. Absolute classic myositis, stroke, scleritis, it's a spectrum. And to those patients who fit the bill, by all means. And then, of course, thyroid eye disease, as we've already discussed. And then finally, I was going to say one or two words about socket exposures. There are yeses and there are nos, and I see this on a pretty much weekly basis. The patient comes along, they say, I've had my ball implant in the socket, it's exposing, I need to see somebody else, they're going to patch it over with something. That's a complete no-no to my mind. Okay, if you've got a socket like this, where they're exposing that hydroxyapatite implant, it's yes, yes, yes to removing it and putting a new one in. Because all that happens is if you mess around with the conjunctiva, it fibroses, it contracts, so that when you do eventually do the right operation, you've got less conjunctiva. So one of the sort of absolute yeses is if you've got some exposing implant, then we remove it and we put a new one in. But if you've got a tiny defect somewhere, you might try and cover it over by bringing the conjugate, but it probably doesn't work. Okay, the question at the back.
You have extrusion of the implant. How quickly would you want to?
What a great question. So the question to the rest of us on that, if you have an extrusion, how quickly? Is this an emergency? Well, do you know what? Curiously, never understood this. It is not an emergency. I would treat it promptly, but I've had patients who've delayed their treatment for month after month, even years, and they can stay like that for literally years, just conjunctiva gradually receding. And there have been cases where the ball just popped out. I think there was one patient, my senior colleague described a patient where the ball just popped out into their breakfast cereal one day. I mean, literally, it can happen. No, you're not going to get that far. You're so good that, of course, you're going to recognize this and you're going to treat it before you get there.
David, can you use buccal mucosa if your conjunctiva is
Well,
pretty?
so the question is, can you use buccal mucosa, which we use often, but of course, a graft requires a blood supply underneath it. And the problem with these is this flora and fauna of the ocular milieu has effectively infected the ball implant. It's everywhere. There are enzymes, there's infection right under the conjunctiva. So what happens is you try and patch it over something, and that breaks apart, and you sort out that, and then it breaks apart over there, and then eventually the whole thing recedes. So I have a low threshold, just going straight for a ball exchange. There's lots of caveats in that, which I won't be talking about just now. Yes.
Mr. Verdi, there's a question here from the chat related to that previous imaging. For apical lesions with vision loss, what are some features that help distinguish infectious, perhaps fungal causes from inflammatory causes on imaging?
Well, it's all about sinuses, and whether the patient's immunocompromised, if you've got a sick patient or a diabetic patient, and it's a fairly slow, don't forget fungus is fairly slow, that's quite different to somebody waking up and finding that their vision's going down and they're in pain as well. So a lot of it's in the history. But a great deal of this is how fast things are happening. So never treat the scan, treat the patient, by which I mean take the history from the patient, because your history will probably narrow down the differential as to whether this could be fungal. Now, if you could work in places like some parts of the world, like India, for example, they've seen a 20-fold increase in fungal infections in the diabetics during the COVID period, as we know. In the UK, we see very little of it, fortunately. So I can't answer that question in terms of 10 patients with fungal, 10 patients with myositis, for example, but they do have a completely different history. You know, you would not have a patient presenting very acutely who was well 3 or 4 or 5 days ago who turned out to have a fungal infection. So it's all about the history. We can talk about that later on if you'd like to. I'm going to look at some fairly serious malignant diseases now. When to intervene? Here is a lady. I remember this well. When patients come to you from other clinics, and it's a cataract clinic, don't just think cataract. Patients come to you with all of their neurology and their health, and there's a trap when patients come to a corneal clinic from an oculoplastics, and we stop thinking outside of the box. This lady, herpetic facial pain, gradually evolving neurology, previous basal cell carcinoma, she thought, she couldn't quite remember, dry eye, so she'd been in a dry eye clinic for quite some time. But nobody really quite realized that she couldn't look to the right because she had a 6th nerve palsy, you see. And when I looked at her and they said, could you sort out this lady's dry eye? I thought, well, this is curious because her corneal sensation is down, she can't look to the side, and she's got a facial weakness. And I can't tell you the number of times in all fields that examining cranial nerves helps you zone in on some fairly serious pathology. Never overlook the cranial nerves. It only takes a few minutes to examine. Here you've got 5, 6, and 7. So we go to our anatomy, and I'll test you all on this later, right? 5, 6, and 7, they're all together at one point, aren't they? Or are they? Well, we've got 5, and we've got 6. But 7 isn't in that diagram, because 7 doesn't come through the orbit, which immediately makes you concerned. Where would 5, 6, and 7 come together? And that's where even the oculoplastic surgeon has to have some understanding of basic neuroanatomy. Mine is fairly basic, okay, but I do know that cranial nerves do not all travel through the orbit. 7 definitely doesn't. And that's where they're together, 5, 6, and 7. Down there you can see in the brainstem. And the course number 7 zips around 6, as you'll remember. I'm sure you remember that from your neuroanatomy days. So this particular lady, we scanned her. I didn't like the fact she had 5, 6, and 7. We scanned her and we see an infraorbital nerve enhancement, as you see on the right there. And taking you back to some of the other questions we had, where you've got abnormal tissue, you need a tissue diagnosis. You've got to have a tissue diagnosis, which is exactly what we achieved in her. But I just show her axial scan now. So we're thinking about the 5th cranial nerve, which goes round behind the brainstem. And I'm afraid she was lighting up all the way around the brainstem there. You can see that quite clearly on that side. So she's got some infiltrative process from the sensory nerves on the skin, which has gone on and to involve the 6th and the 7th. So therefore, we took tissue. What we're looking at here on the top left is the orbital floor with the malleable holding the globe safely to one side. There's the orbital floor, deroofing the nerve. That's the infraorbital nerve, taking the bone off it. Taking tissue, she said, Doc, don't cut right across the nerve. I need my sensation. So I thought we'll cut a longitudinal stretch as we did here, a longitudinal stretch leaving some of the nerve behind. And of course, what do you think the diagnosis was? She thought she'd had a BCC. Well done, squamous cell carcinoma, okay? That's exactly with perineal infiltration, and that's exactly what it was. It was a squamous cell carcinoma. Very sad, and ultimately she succumbed to that disease despite her heroic fight against disease. Now, a few words about lacrimal gland tumors, when to intervene, when not to. There's a lot of mystery surrounding lacrimal gland tumors, but in this case, a lot of the answers are based on the scans. If you have a patient with swelling in the lacrimal gland area, and it's well defined, as you see here, it is almost certainly to be a pleomorphic adenoma, which you've probably heard of. Pleomorphic adenomas should not be biopsied. They should be removed intact. So that's a distinct yes. If you see this, yes to intact excision. That's so important. Never biopsy anything that looks like this on a scan if it's well defined. If, on the other hand, you have lacrimal pathology, and as I say, I just sent one this morning, I'll show some of you afterwards, where you've got the diffuse cloaking around the globe, particularly with pain, suspect neoplasia or inflammation, and take a biopsy as soon as you can. So in this particular case, for example, ill-defined mass around the globe, possible carcinoma, it's a young person's disease, it's a dreadful disease, and when you see a picture like that, it's probably inflammatory, but bear in mind it could be neoplastic, an early biopsy, and we just take a biopsy, and if it does come back as carcinoma, we then go back and remove as much of it as we can, or all of it, and then post-operative radiotherapy. We no longer exenterate. So we do an early biopsy, and we don't open the periosteum, and we do not exenterate these patients. That's a big no now, because exenterating these patients with tumors of the lacrimal gland does not improve their life, and it's a mutilating disease, it's a mutilating intervention. So there you see adenoid cystic carcinoma. Remember this young lady so well. Sadly, she's no longer with us. And this is a rare disease, but we see it every few months or so in Moorfields Eye Hospital. And I mentioned that exenteration does not improve this poor lady's outcome. This is an adenoid cystic carcinoma, and it can spread to the lungs and elsewhere. And so that's why the patient comes along with a bit of pain and swelling, you put them on steroids, and 3 months later they're still on steroids, but they have this diagnosis to have a low threshold for tissue biopsy. Okay, so I've spoken about some things that are clear and some things that we shouldn't do in terms of we don't give steroids, but we do interact early with infections. But there's a lot of gray areas in between. We're making progress, we just got a firm maybe. There's a lot of areas in my job where things are genuinely gray. And the secret is to know what's gray and what's not gray, because there aren't answers to everything just yet. And so there's lots of things in the maybe camp. Should you intervene, should you not? I'm not going to go into all of these, but when to intervene and when not. A patient has a hemorrhage, for example, elderly lady, ectatic vessels in the orbit, she coughs and she has a hemorrhage. When should you drain a hemorrhage? Most of the time, probably not, but using first principles, if the patient's not getting better or there's visual loss, consider reducing and draining the hemorrhage. It's a nice picture this, because you can see, obviously she's not standing up for the CT, I've moved it through 90 degrees, but this patient is lying down, you can see one hemorrhage fresh on top of another hemorrhage. And this has caused ptosis, and her visual acuity had dropped. And then I drained it. And what do oculoplastic surgeons always do after surgery? They show a happy patient. All right. But the point is that not all orbital hemorrhages require drain, but many of them do if the patient is progressing or the vision starting to drop. Now here's another lovely example. This is a maybe. This is a maybe. You can see one hemorrhage, 2 hemorrhages, and a cap on the second, right? It's the third hemorrhage up there. And so with this patient, we swung the lid. This is a lower lid swing flap, very easy to do. We distract the lower lid from the orbital rib here, put 2 mandibles there. It's difficult to see, but there's one mandible on the bottom left. For those watching us virtually, 2 mandibles on the left, and you can see this, it's actually a venous lymphatic malformation, and we drained that. And the patient got better, but of course we hadn't removed the malformation. 3 years later, unfortunately the same thing, but on both occasions his vision improved. It's much more difficult when it comes to vascular lesions that are the so-called cavernous hemangiomas. Has anybody heard of a cavernous? You've all heard of a cavernous hemangioma. It's actually got a different name. It's technically called solitary encapsulated venous lymphatic malformation. That's quite a mouthful. So we still stick with cavernous hemangioma. And it's one of the commonest adult orbital tumours. And the question is always when to go in there. I have got 2 or 3 patients at the moment that I'm feeling very yes-nabby about. 6'6", full colours, 3 millimeters of proptosis. Patient's not happy, young lady. And you know there's a risk of surgery. It's not small, a risk of double vision, ptosis, visual loss. And so it's very difficult, and particularly when they start to develop a presbyopic correction because the mass is compressing the back of the globe choroidal folds, their prescription's gone up by +1 or +2. And when it starts to march, and these diseases have a growth phase and they don't always carry on, but if they do, you have to intervene. Then when you recognize this change in vision down to maybe 6'9", 6'12", then it's a yes. But until that point, it's a yes-nabby. And if they're discovered coincidentally, which I see every week, had a migraine doctor, had a scan, they found a cavernous hemangioma on the orbit, I say, don't let any doctor touch you. You don't want too many doctors. Okay, that's what Hippocrates said. One general physician and not too many specialists. Okay, so surgery for foreign bodies, wrapping up towards the end. Always hard to know what to do when a patient has a foreign body in the orbit. Must it be removed? Should you leave it? Can you afford to leave it? And when do you go in there? It's a yes, no, and it's a yes, maybe some in the middle. This patient's a no. This patient's got a pellet in the orbit. Totally normal orbital functions. Patients can get a little bit obsessive about the fact they have an orbital foreign body and they definitely want them removed. We've all seen that. But you've got to hold your ground and say, no, everything is working. And even if we do go in, we probably won't find it. Looks easy on the scan. When you're there in reality, it's anything but easy. So that's a definite no for that one. And here you see another one. This is a definite no. There's the orbital foreign body just there. This one's a bit more of a yes, okay, just to make sure you're still awake. This poor lady in Scotland fell down the steps with their key. Yeah, she did well though. Okay, that's just to make sure we're all still awake, which we are. And this one's a yes. Do not try to fix your washing machine at home. Washing machines have springs and springs can shoot out at high speed, as you can see there. But this one's more difficult. He's got an orbital foreign body. I've shown that already. The problem is he can't have an MRI scan for his back. He's got lumbar spine problems. So we actually removed the foreign body, as you can see here, in his orbit. Rather difficult to find, but it's smack up against the bone. So we did get that. So he could have his MRI scan of the spine. All right. That's just an interesting aside, if you can see that there. It wasn't small either. And then you've got these difficult venous anomalies, varicose veins. You've heard of varicose veins, you can get them in the orbit. And they are a nightmare to treat. By the way, if you've got a patient with a varicose, you've all seen these varicoses, look in their mouth at the same time. You'll often see ipsilateral, hard and soft palate changes like that. And you really only want to go in there if you have to and your arm is twisted, by and large, because you don't see size at all. And they can get bigger, and the patient's not always happy. And then I think one of my favorite yes-nabbies is what I call the gap of great expectations in thyroid eye disease. You've seen this picture before, and we've treated them, and the blue line is how they look, and we're getting them better and better and better. And right towards the end, you've done the decompression, squint surgery, you've lowered the lids, the patient's not still quite happy. And they say, well, doctor, you've done so much surgery, I'm so much better. You can really make me look normal again. And that's 4 years after it all started. And they come in with a picture of themselves in a Vogue magazine and say, doctor, I was like this before, or a wedding photograph, and your heart sinks. And I call this the gap of great expectations between what the patient wants and what the surgeon can deliver. And it's very important at that point to say, enough is enough. And it's knowing when to not do anything more. And that's really, it goes from being, yes, we can help you at the beginning, as I've shown you, to yes, maybe we can do more, to no, we shan't now. And it is a yes, maybe really starts to become, sadly, sometimes a no. And you have to hold your ground sometimes because you can be pushed beyond what you can deliver. Always under promise and over deliver in medicine. There are times when you've got to say no. A couple of other conditions here, dermoplipomas. You've seen these before. Benign conditions. You've all seen, you put your hand up, you've seen a dermolipoma. It's a benign condition, but the surgery can be more dangerous than the condition. And we only trim these down if you can see them in the primary position, because much grief can come from inappropriate, excessive removal of a dermolipoma, like this poor gentleman who came to us from abroad, and he had it all removed, and the eye was pulled up and did an hyper-exo, as you can see here, and it really wasn't good at all. So dermolipomas, hold back, make it a no for you, and it's a yes maybe for the orbital surgeon. Okay, but it's not a definite yes and just go and remove it. So a couple of bonus cases have been done. Bonus case number one. Now this is a case that Dr. Khan will remember very well because she helped me through this in Moorfields. This lady came along and she had an eye like this and she had a huge mass and she had lost most of her vision. She was down to counting fingers, and Michelle will remember this very well. And we thought, well, you've lost much of your vision. We don't know what this is. We need a tissue biopsy, or more than that, we need a proper debulk. So we use this lovely instrument called the Elman radio frequency. It's got a little ring at the end, as you see here, and that really, like a knife through butter, hot knife through butter, carves out all of this tissue that you can see here. And this is what it was, and it was a yes. We would debulk that, protected the cornea, and incredibly, and I only saw her last year, she's now seeing about 6-12. 3 or 4 years later or so. So thank you very much to Michelle Kant for your help with that, because I remember it was a sweaty moment, to say the least. But she's done very well. Bonus case number two. I've got this case at the moment, only saw him last week. This is a no and a biopsy yes. This man, a bit of a swelling, thinks he's got a mucocele, poor gentleman. He's had a lot of health concerns in the family with his children, so he didn't worry too much about his mucocele, which is just a description. Turns out it was rather solid, rather firm, and when we do a scan, you see he's got not just a mucocele, but tissue running into the nasolacrimal duct, as you see around here. So absolutely yes, we need a tissue diagnosis. Absolutely yes, and urgently, which we did 3 or 4 days ago. And there you can see my numbering, because the oncologist said, you know what, his skin's involved as well. So take a lot. So there we are, 1, 2, 3, 4, 5, 6 skin, 7 was deep. And they all came back, skin just showing inflammation, got it back through yesterday morning. But the deep one shows tumour in the lacrimal sac. And that raises a very difficult question about how do you treat these patients? Do you exenterate? Do you just remove the lacrimal sac and the duct? Do you do radiotherapy? Well, the answer is we don't exenterate. It's a difficult disease to treat. So that, for me, is still a bit of a yes and a B, grayish area. I work with the NT surgeons, oncologists, because you have to work as a team, and some of these conditions are so difficult. So exenteration in him? No, that's not him. You don't exenterate for all neoplastic disease. That's a big no. And the last bonus case, this is a maybe, but not yet, all right? This is another poor lady that I was treating recently. She comes along, a little bit of a fullness of a conjunctiva, nothing very worrying really there. You do the scan and you find that actually she has a mass on her orbital floor, okay? I mean, this sort of thing walks through the doors of Moorfields not infrequently when you've got a large enough catchment area. I'm sure it's the same here in Canada. And you can see this mass on the floor running down into the duct. All she was aware of was some conjunctival thickening on that side, right? And there you see the PET scan lighting up, because the biopsy, always get a tissue biopsy, showed that it was a squamous cell carcinoma. There you see the squamous cell carcinoma. And the histology was squamous cell carcinoma, invasive. What on earth do you do next about a young lady with normal vision, with a lesion under her eye, absolutely perfect normal vision? So you think, well, these are my options. The immunotherapy, exenteration, radio, debulk. Where do you go with this? Well, you work with a multidisciplinary team environment. It's critical in our job. We work with teams of people. So we decided, in principle, immunotherapy, we're going to keep a watch on her. More immunotherapy if she was improving, possibly debulk, and just keep watching her like that. And then radiotherapy. We thought we have a plan, but not all plans go according to plan. Because actually, the worry is while you're doing this, you're losing that window of effective treatment, young lady in her 40s. So we gave her cemiplimab, and basically there's a tumor cell, and T cells tolerate tumor cells like you see on the left. But if you can block the tolerance by putting on cemiplimab, the T cell says you're a tumor cell and you're finished. And that's how these immunotherapy regimes work. So we did this for this lady, 40 years old, perfect vision, normal eye movements, immunotherapy, surveillance. And then sadly, a few weeks ago, it increased the tumor size, and now she's just had an exenteration. So it's about suspicion and getting tissue biopsies as soon as you can in ocular plastics. And the worry is, did we actually extend the window necessarily? So in summary, yes, Count, we always intervene for diseases which threaten sight or life, or where surgery is acceptable for aesthetic reasons. I don't mean a cosmetic surgery, I mean for aesthetic reasons. We do not intervene, we decide not to intervene if the disease is not going to reduce the vision in the longer term, probably like a cavernous haemangioma, or is not going to threaten life at all. And we've got this very difficult interim place, the maybe, the not yet, the not today. And that's where we work with colleagues so we can share the load and some of the concern as to how to treat some of these patients. And that's a maybe. And every day I live as you do with yes, no's and the maybes. And we're trying to narrow down the maybes. Is it yes or is it no? and does time push it in one direction or another? So here we go back to Professor Slomovich again, of course, and he's thinking, yes, I'm going to intervene with this corneal case. I'm definitely not, because it's not worth the patient for the patient. Maybe, and then there's a yes maybe. Maybe, but maybe not today. Thank you very much indeed for your attention. Questions?
Just wondering which of the vascular orbital lesions that manage expectantly and then they can present with an acute bleed, hemorrhage, or like
Yes, right.
orbital compartment may be possible.
So we're curiously, the high flow lesions, which are things like AV malformations, do not present with hemorrhage. It's a paradox. Low flow lesions often can present with a venous, and those are ectatic vessels in the elderly. So the patient that I showed you, those are just loose ectatic vessels. Cavernous hemangiomas, I think it's fair to say almost never bleed. There's almost no never in medicine, is there? I've never seen one. So great big lesion, you think this is going to bleed, it doesn't. Cavernous hemangiomas do not bleed. AV malformations, curiously, at least I have not yet seen one bleed until you start to operate on them, that's another matter. But those that do bleed tend to be the venous malformations, the venous vascular malformations, or the VVM, and the venous lymphatic malformations, the VLMs. Okay, so those are the ones with the venous component. And the lymphatic malformations as well. So a patient has a bit of a chest, bit of a respiratory cough, coughing away, they've got a venous lymphatic malformation, it can bleed into the lumen. Although the only advantage is that with recurrent bleeds into these lesions, with the inflammation, they probably shrink down in time, probably. But there are sclerotherapies that can be used for those that do cause recurrent trouble, as you know. Sorry, question at the back.
So recently I saw a case of periorbital necrotizing fasciitis. So within the next 24 hours, the infection spread from the orbit to the left chest and left back, and with some necrotic tissue. That's why the surgeon decided to debride. I'm just wondering, for neck fascia around the eyelid, is it more common to spread around or spread deep into the orbit?
It's not common to spread deep into the orbit, but it can happen. You see, the tissue planes, as you said, that the plane from the eye to the neck is very, very quick. I mean, it can open up very quickly, and that's why it spreads in that direction. It's unusual for all the ones that I've seen. The treatment is not an exenteration that you would hold for fungal infections, which have a completely different course, much slower. The treatment is local. It goes down to that certain plane, and then it goes along, and it can go down to the neck very, very quickly. It's much less common to track into the orbit because you've got the septum, and it's a tightly packed area, whereas the potential planes in the skin or below the skin will open up into the neck and the side of the chest very quickly. So the answer to your question is it doesn't tend to go deep into the orbit. It'll be superficial spreading, and at a pace, you draw a blue line around it, then you come back 2 hours later, crikey, it's moving, we need to go back, and you might need to go back to theatre twice in one day, day after day, whatever it takes. Horrible condition.
Question. Thank you, Mr. Verdi. It was a very gripping talk. I think we all can say that there's so much that we don't know. My question is about your bonus case number 3. What precipitated you to order imaging on that patient?
So the bonus case number 3 is the gentleman that I'm managing at the moment. And he came to me with imaging because when the referring surgeon gently palpated it, he thought this is a craggy mass. It's not a soft mucosal. The problem is that common things are common. What's the other half of that sentence? Rare things happen. Okay, so don't be fooled just because you think it's a common thing. Yes, common things are common, but rare pathology happens all the time. And the bigger your catchment area, the more you'll see these random things. So always feel, I was always trained to put a hand on your patient. Put a hand on your patient. I don't know if anybody read Daily in Love, probably not. It's an old textbook. My grandfather was the editor for 35 years. And he always taught me, he said, as a medical student, always put a hand on your patient every day. You can't quite do that in ophthalmology so much, but you should palpate around the orbit. And this felt hard and craggy and indistinct. And the other messages, this is a really important one. If a craggy mass can be felt above the medial canthal tendon, that is much less likely to be a mucosal. In fact, the odds ratio for it being a carcinoma, if you can feel a mucosal above the medial canthal tendon, shoots up to about 8 or 9. Okay,
Thank you.
so palpation.
Just a question about the thyroid eye disease. Just wondering for the immunobiological treatment with the teprotumumab, What's the guideline of using? Do you actually start using it early? And what if a patient presented late with like imminent optic neuropathy? Would you still try it, or
So,
would you?
can we just, so the question is related, just to ask on the call, the question relates to thyroid eye disease, so the treatment in acute phase, and the treatment with which medication?
The insulin growth factor?
Oh, so teprotumumab. Well, at the moment, it's on a trial basis only, it's a study drug only in the UK. But what we're seeing is that it can really reduce the likelihood of having to orbitally decompress for optic neuropathy. And it will, in your lifetime, very soon be a first-line drug for active inflammation, because it takes the volume down. It's all about volume. That's all it is, really. It takes the volume down. But the really interesting thing, not answering your question, well, I do, because it will, if it's available first line, there are many people who would say use it first line, but it's not without side effects. All these immunotherapy ones have inflammatory side effects, but it also seems to work in patients who've had too much volume exophthalmos for years and years. And Suzanne Freitag, I gave a talk on this. She gave me quite a lot of her slides from Massachusetts, Harvard, and she's shown pictures where patients actually do improve years down the line. But she's shown some incredible pictures of patients who failed on IVMP, but did not fail on teprotumumab. So I don't profess to any working knowledge of it myself, other than what I've seen other people tell me. So you're living in a really important age. You're living in an age of AI, come tomorrow if you have got a ticket, try to. And you're living in an age of immunotherapy. It's not chemo, it's immunotherapy. It just tells the body to wake up and blocking all these pathways. When I was a lad, we had immunology by Reut and Reut, and we had a few cartoons and there wasn't much in there. It's a completely new world. But so definitely teprotumumab will be a first-line drug, I suspect, within the next 5 to 10 years for certain patients, acute patients.
And then even can you use it even in like late stages when you have like imminent
So
optic
the question is, can you use teprotumumab in the late phases? As I say, I don't have any direct experience, but I've seen patients where exophthalmos can reduce years later. It changes the way the fibroblasts seem to be in a chronic phase of overproducing, keeping that volume high, keeping the exophthalmos out there. So it's a steady state that is a constant perpetuation of the same issue. Not acute any longer, but it's a perpetuation. And teprotumumab apparently improves that. So patients, I've seen them get better, seen pictures of patients better, which I find incredible. Yeah. Probably used up our time, I suspect. One more question.
Last question, I guess. In thyroid eye disease, how effective can smoking cessation be, your experience, and how often can you actually achieve smoking cessation in your patients?
So the question is about thyroid eye disease and smoking. If you have a patient and they're not responding to the treatment, 9 times out of 10 they're still smoking. And when they tell you they're not smoking that much, but we all know what that means. But humans are humans. We can't tell people just to do things. Otherwise, they tell people to stop drinking fizzy drinks and beast to be sold tomorrow almost. But the reality is that when they're starting to lose their eyesight, or they're having such discomfort and pain and swelling, they're more likely to cut down. It increases the inflammatory response multiple folds, many times. So the answer is, it's one of the few things you can change. I was going to say you can't change gender, but I mean, these days you can, but it's gender, thyroid control, and smoking. Those are the 3 things. And you can influence thyroid control. And even being in a smoking environment increases the risk of inflammation. So it's extremely important not to smoke in the acute phases. But I always say to patients, I'm not here to lecture anybody. I can't tell you why, but if you do stop smoking, there's a good chance that we can treat you more effectively.
How many patients actually achieve
Quite a few of them do, actually. Yeah, quite a few of them do. I think there's something about eyesight and potential loss of eyesight. That's a wake-up call for many. But the key thing is, we know the lecture patients are on their side. We're trying to help through. We say, you're not going to do it overnight, but let's just bring it down as well as you can. That raises the question as to whether vaping or not makes thyroid. I don't know the answer to that one. So don't answer that question.
All right, well, thank you very much. I appreciate you coming in all the way from London. Wonderful meeting planned at Ellen as well. So for those of you who have registered to consider, we look forward to your talks tomorrow, but thank you for the wonderful session this morning.
Thank you very much. Great audience. Thank you.